Let's move to the scientific program. Happy to announce the first speaker. He's already standing there. He's from close by. He's also from Utrecht, but he's in the hospital, in the Utrecht Medical Center and in the Maxima Hospital. And actually also nowadays, you moved a lot in recent years. I know you very well from several PhDs we shared in Rotterdam, but that is ages ago, I think. And since then you were in France and now in Holland and Germany again, in Munich, at the Maximilian University and the Technical University also. And so a very active man, an expert in cancer immunotherapy, clinical expert, very well recognized, more than 1,000 papers, and so on, and so on, and so on. But time limits the introduction. Please take the floor.
So I take micro 3. Yeah, thank you very much. Yeah, I prefer to take a mic so I can walk around and I can look at you and look at the screen. So this is going to be not a nano, but a macro talk. I quickly take you from the landscape of adjuvant immunotherapy in melanoma to what is the current revolution in immunotherapy. It's neoadjuvant immunotherapy, and it will completely dominate what we will be doing over the next 5 years. So melanoma was an untreatable disease if it had palpable lymph nodes or distant metastatic disease. Basically, everybody would die, and this is only 12 years ago. Then we got, after we wrestled with interferons for 20 years, which were never really effective, we got a new era in melanoma. And it was with the checkpoint inhibitors. It was with ipilimumab, anti-CTLA-4, nivolumab, anti-PD-1, the bottom, the other anti-PD-1, pembrolizumab. And if you have a BRAF mutant melanoma, you have an additional option, and that would be dabrafenib plus trametinib or any other BRAF-MEK inhibitor combination. The immunotherapies work for all melanomas, regardless of mutational status. So in the new adjuvant era, we got rapid approvals for everything that worked, also in the advanced setting. So the first trial we did was ipilimumab versus placebo in lymph node positive melanoma. Lymph node positive melanoma, if you have palpable nodes, 90%, 95% will relapse and die in the old days. If you have only a microscopic one lymph node, the relapse rate will be only 35%. So it's a very broad spectrum of risks. Ipilimumab was approved on a hazard ratio of 0.75. What does it mean? If you randomize it against placebo after a lymph node dissection, you reduce the relapse rate by 25%. That's what hazard ratio 0.75 means. Then nivolumab, the anti-PD-1, is better than ipilimumab, as was shown in the trial Nivo versus Ipi, with a hazard ratio of 0.65. The BRAF-MEK combo only in the BRAF mutant melanomas showed a more or less 0.50 hazard ratio, but only in those 40% of melanoma patients. And the pembrolizumab trial showed 0.57, so a 43% reduction of relapses in all melanomas, regardless of mutational status. So that is our point of departure. This slide is in, even though it's the weakest agent of the four, that what you see in relapse-free survival benefit, you see exactly the same thing in distant metastasis-free survival, and you see exactly the same hazard ratio in overall survival. This is phenomenally important, and it's a hallmark of immunotherapies, is that the responders are all good responders. They are long-lasting responses, and actually you do cure a fraction of the patients. It's not that clear with a lot of targeted therapies, and it's not that clear with chemotherapeutics, where you may have relapse, where you may have response rates in advanced disease, but most of them are short-lived, whereas in immunotherapeutics, when you do respond, you're actually almost always a good responder with a chance for cure. So, focusing on the last anti-PD-1 trial that I show here, pembrolizumab versus placebo, this is the impact on relapse-free survival. The top curve is pembrolizumab, the bottom curve is placebo, okay? So that's understandable. But this is an important slide to see where the problems that we create ourselves are gonna go. If you have very high-risk disease, palpable nodal disease, 3C, the benefit in absolute terms is about 25%. But if you have only microscopic nodes, 3A, the benefit at best would be 15%. So if you have a hazard ratio of 0.50, there the benefit actually in terms of absolute numbers of patients is much greater than what you can achieve in lower stages. And I will dwell on the problem that we are creating ourselves. This is the last publication on this trial, 5-year update, relapse-free survival. It's the same hazard ratio for distant metastasis-free survival, and it's the same hazard ratio basically, even if you crossed over the placebo patients in giving them anti-PD-1 later once they have relapsed. Okay, so the benefit of adjuvant is retained. Now, then, of course, you try it out in lower risk patient populations, and those are the stages 2B and 2C, meaning these are lymph node negative patients. They are lymph node negative patients, they have a better prognosis. And there's 2 trials, pembrolizumab, left trial, nivolumab, the right trial, the anti-PD-1 molecules in melanoma. And so the first trial was the first one to be reported. But now you see that the relapse rates, the bottom curves of the placebo patients, are much closer to the anti-PD-1 curves. Why is that? Because the relapse rates are much lower. So it's clear that if a relapse rate over 3 years would be only 10%, then you can have a hazard ratio of 0.50, but then that relapse rate has been reduced only by 5%. What does that mean? That you basically need to treat 20 patients for one to benefit. And if you need to treat 20 patients at 150,000 euros per year to benefit one patient, you have a societal problem. And so, where we create clear benefit in the high-risk patient populations, we create a problem in the very low-risk patient populations. So, in the end, then, we have split up the decisions between EMA approval and reimbursement, because the reimbursement is what society is willing to pay in the end for the same hazard ratio, but in a category of patients where you say, well, I don't know, if this is really worth it, because 20 patients are being exposed to a drug that gives in 20% of the patients hypothyroidism, and in 1% type 1 diabetes, but in 7% pneumonitis, and in 3% inflammatory bowel disease, meaning that when you see the picture of what you induce in collateral damage, the discussion is very different in the lower risk patient groups than in the extremely high risk patient groups. So this is the status of affairs with adjuvant therapies. So in stage 3, you need to treat 6 to 8 to benefit one. But in stage 2BC, you need to treat actually 15 to 20 to benefit one. All right? So what do we need? We actually need to be able to identify at first diagnosis, when we get the primary melanoma, that we have techniques that identify those patients who will relapse and those patients who have extremely low risk of relapsing. And then we would solve the problem, because only in the patients who were identified of being really at high risk would you contemplate offering adjuvant therapy or participation in an adjuvant therapy trial. Are we going there? Well, yeah, we're going there. So a GEP, gene expression profile in melanoma, combined with CP, means clinical pathologic characteristics. It's only 2. The C is clinical, it's the age. It's known of all patients. The P is pathologic. It's the thickness of the primary melanoma. This is the thing that's always known of all melanomas. And then you have a gene expression profile with 8 genes and 2 housekeeping genes. That algorithm actually provides you with the dark blue curve, because the top curve are lymph node negative patients with a low risk algorithm outcome. The bottom curve are lymph node positive patients, and they are 100% also high risk algorithm patients. But the line of interest are the patients who are lymph node negative, so sentinel node negative patients, but they still relapse. And they were identified as high risk by the algorithm. And so the algorithm would be the upfront selection mechanism to identify patients who merit contemplation for adjuvant therapy schedules. It translates into distant metastasis-free dark blue curve and into a melanoma-specific survival curve. And there's now a new 7-protein prognostic immunohistochemistry assay that is emerging that is even producing better curves than this. If you have a low-risk profile with this one on your primary melanoma, and it's low risk, you're almost certain not to relapse. It means you can make much easier the follow-up schedules. You don't need all these CT scans and all this, because basically you're not going to relapse. And you should not be offered adjuvant therapy and pick up the risks of collateral damage of adjuvant therapy. But if you are the red line, a high-risk identifier on your primary melanoma, you know that 25% has relapsed at 5 years, 10% has relapsed at 10 years, and actually all those patients will go on to distant metastatic disease and have limited life expectations. So that dichotomy identifies the patients who can choose and opt for adjuvant therapy, or we should design a trial in the lower categories of melanoma risk patients that are identified by this test to yes, no, be included in the adjuvant therapy trial. And it even translates into melanoma-specific survival. So there was only 1% that still relapsed and died of melanoma in the low-risk profile, right? So you're not going to do adjuvant therapy in those patients. So that is where, in the end, we are also at the same time getting stuck with our adjuvant trials because we are trying to expand it too much in the lower categories of patients without a dichotomy diagnostic tool. Now, the quickest way to actually identify if immunotherapy makes sense is to work with the patients who have palpable nodal disease in melanoma, because 95% will relapse and die. And if you then give your immunotherapy up front, you will identify if they respond. And if they respond, they're all good responders, and it's your best opportunity to cure those patients. So we call that neoadjuvant immunotherapy. So you start systemic therapy before the planned operation. And there are 3 benefits here. There are more cures, there's shorter treatments, and there is less surgery. I'll give you the example. So palpable nodes, and we used to operate and then give adjuvant therapy. Now you give your neoadjuvant therapy, and all the good responders, pathologic complete or near complete responders of the indicator node, don't need any operation anymore. And actually, they don't relapse anymore because they're actually cured. So if you just give the first 3 doses of an adjuvant therapy with anti-PD-1 before the operation, you get the blue curve, as compared to if you do the operation first and then give all 18 doses after the operation. And this is already now declared the new standard of care in Australia, although in Europe and the US we're still, bickering with the regulatory agencies how to recognize defined best medical practice and define it as standard of care. This is the landmark paper in Nature Medicine, and it explains the recipe for cure. 10 patients, red, palpable lymph nodes, surgery followed by adjuvant ipi-nivo, is anti-CTLA-4 plus anti-PD-1. Only 2 cycles. Bottom, 10 patients, 2 cycles of ipi-nivo, and then do the lymph node dissection. All right? And here you look at the T-cell clone patterns in these patients. The red ones, where you can only work with minimal residual disease when you give your ipi-nivo, have a limited amount of clones, T-cell clones, and amplitudes of T-cell clones. So diversity and amplitude is limited. When you give the 2 cycles prior to the surgery, you have worked with all those lymph nodes that are very rich in lymphocytes that are in touch and are there, and you have a lot of tumor-infiltrating lymphocytes. You expand tremendously the amplitudes of all the clones. You expand tremendously the neoantigens that you have induced with your immunotherapy. And so you end up with more than 200 times more T-cell clones, also in diversity, than before. That, everybody can understand, is a recipe for cure. So what do they find? They find that in the top green curve, those were the patients who have a pathologic complete response or near complete response of the lymph node, right? Or one of the many lymph nodes. They don't relapse anymore. One patient died, little star, in a traffic accident without having disease. There was only one patient out of 64 who relapsed. One. We have never, ever seen these kind of data in the history of melanoma. If you don't respond, which is about 30% of the patients, you have innate resistance that is so bad that you can't even respond under the best of circumstances. That means don't try anything and continue with anti-PD-1 or with other things in these patients. They need something totally different because they are primary innate resistance to immunotherapy. So in a pooled analysis with other groups in Sydney and in Houston and so on, the top curves are the patients with palpable nodal disease who received neoadjuvant anti-PD-1 based therapies. Basically, nobody responded if they had a pathologic response. If you do the same thing with targeted therapies, dabrafenib plus trametinib, even the best pathologic complete responders relapse. And if you don't have a pathologic complete response, you don't get any benefit for your neoadjuvant therapy. And so in another trial, we then stopped doing lymph node dissections. Look at the top red box. In anybody who had one node where there was a pathologic complete or near complete response. So less surgery, more cures, shorter treatments. Why shorter treatments? None of them got any adjuvant immunotherapy. And you think, well, this is just a melanoma story. No, it's not. It's the same thing with cutaneous squamous cell cancers in the face. They are no longer operated with big plastic surgery. They get neoadjuvant anti-PD-1. It's the same thing with MSI colorectal cancer. Look at these waterfall plots. This is Niagara Falls. They all have a complete response. They all have a complete response. If you have an MSI colorectal cancer, you should not be programmed for surgery. You must get neoadjuvant ipi-nivo. And 92% of those patients will not need any surgery anymore, and they are cured. You see it even in lung cancer, where you see a 12-fold increase of pathologic complete response rates in advanced local lung cancers if you add anti-PD-1 and ipi compared to the chemo. And so, with bladder cancers, this was published 5 days ago, so I couldn't show you the figure. It's the last slide. It's the last slide. 40% of patients with a bladder cancer do not need a resection of their urinary bladder anymore. This is a new revolution, and that's why we should be doing this. Even in glioblastoma multiforme, 1 dose of anti-PD-1 prior to the resection of a recurrence leads to this benefit. And that's why this will totally dominate the scene for 5 years on in cancer.
Thanks so much for a great overview and a positive ending.